Hello, I'm Martin Prince, and I'm the Joint Director of the Centre for Global Mental Health, which is a research centre run jointly between King's College London and the London School of Hygiene and Tropical Medicine. And my Joint Director of the London School of Hygiene and Tropical Medicine is Ricardo Araya. Today I'm going to introduce you to some of the topics and themes that we discuss in the Master's degree in Global Mental Health. And the focus of this talk is on closing the gap. So this is looking at the proportion of people who might benefit from evidence-based treatment and care for mental health conditions compared with those that are actually receiving that treatment. And then on the other hand, the challenges of scaling up packages of care for people with mental health conditions in resource-poor, low-income countries. So the first thing that we should consider is what is global mental health, the theme for our research centre. Global health was helpfully defined by Copland and the Lancet in 2009 as an area for study, research and practice that places a priority on improving health and achieving equity in health for all people worldwide. Essentially, with global mental health, we're looking at the application of these principles to the domain of mental ill health. And there's a couple of issues here that I would like to draw out for you. First of all, there's a great deal to be done as regards improving mental health worldwide, because it's widely acknowledged that the outcomes that we achieve in high-income countries, as well as in low- and middle-income countries, are very much suboptimal. The second is that there's probably no other domain in global health where equity is such a pronounced issue as in global mental health. So first of all, there's a gross inequity in the distribution of resources, human resources and other resources, for attention and care to people with mental health conditions between low-income countries at one end of the spectrum and high-income countries at the other end of the spectrum. Secondly, there's a gross inequity in the distribution of resources provided for general health conditions and then those that are actually provided for people with mental health conditions. Thirdly, people with mental health conditions are disadvantaged in a variety of ways, and here I'd like in particular to draw attention to the stigma attached still to mental health conditions in many parts of the world, and also the discrimination that many people with mental health conditions experience in their daily lives, resulting in a lack of respect and often a gross violation of their basic human rights. So it's attention to these inequities that is really at the very core of everything that we try to do. The second thing that I would like to highlight here is that when we're talking about mental health, we're not making any artificial distinctions between mind and brain. So we're talking about mental and neurological disorders. So this is any priority disorder affecting the brain, and we would in particular include conditions such as epilepsy here, which whilst in many countries this would be considered to be a neurological condition, in lower middle income countries, usually if any treatment or care is provided, it's provided by psychiatrists and mental health services. The treatment gap, as with mental health conditions, is enormous, with most people with epilepsy not receiving evidence-based treatment and care. And epilepsy is widely considered in many low-income countries to be a mental condition or a type of madness, and again it's a condition associated with a great deal of stigma and discrimination. So it's really meaningless to make artificial distinctions between conditions like epilepsy on the one hand and conditions that are considered to be psychiatric disorders such as schizophrenia, depression, alcohol or substance use disorders on the other. So in this talk we're going to be considering 4 foundational areas for the discipline of global mental health. The first one of these is cross-cultural perspectives of mental illness and mental ill health, and what that tells us about the universality or otherwise of concepts of mental disorder. Next, we're going to be looking at the evidence that exists for the burden of mental health conditions worldwide, and why there might be some truth in the slogan, "There can be no health without mental health." Next, we're going to be exploring the issues of inequity and human rights of people affected with mental disorders. And finally, we're going to be looking at some of the evidence that exists to support interventions for mental health conditions when provided usually by non-specialist healthcare workers using a task-shifting or task-sharing model integrated within primary care. So what is the evidence that we actually have interventions that can be made to work? Then we're going to be looking at some of the implementation science issues where the questions are not what works, but given what we know about what works, how can we actually deliver these interventions to people at scale so they're accessible. So firstly, cross-cultural perspectives on mental health. This is a topic area which is considered in great depth in the course of the master's degree in global mental health because it's absolutely fundamental to everything that we do. It also needs to be acknowledged that this is a controversial area. So, for example, some critics of the discipline of global mental health allege that this is in essence an attempt to introduce failed treatments, in particular pharmacological drug treatments for depression, for example, which have been shown to be ineffective in high-income countries, to large markets in low and middle-income countries. Now, this is a discourse which is out there, and it certainly can be challenged and defended. There is evidence that pharmacological treatments for depression and other mental health conditions can be helpful. However, it's also probably true that these interventions have been overused in high-income countries and not linked firmly always to the evidence-based indications. But the major challenge really from the cross-cultural perspectives is whether it's appropriate or not to apply diagnostic labels like major depression or schizophrenia or other forms of psychoses to low and middle income countries where the culture is often very different, where the language is different, where the experience of mental health conditions may be different, and where some allege the conditions themselves may be substantially different as well. So there's a large evidence base now from anthropological and ethnographic research carried out in low and middle income countries over the last 30 years or so that indicates that the major conditions of mental disorders, the major categories, that is mood disorders like depression and anxiety, psychoses such as schizophrenia and bipolar affective disorder, and alcohol and substance use disorders and epilepsy, tend to be identified in all cultures where this is tested out. And usually the general approach that is used is a very open-ended, qualitative, anthropological type of study where one presents simple vignettes of the sort of symptoms that one might present in a case of mental distress and asks if people, lay people, community leaders, religious leaders, traditional healers, as well as biomedical practitioners, might have encountered people with these sorts of issues and problems. If so, how do they present? What sort of symptoms do they present with? What language do they use to describe those conditions? What might be the course and outcome of those conditions? And then one has an ability to be able to compare the syndromes and how they present between different cultures and between low middle income country settings and high income country settings to test the hypothesis that these major categories have some validity between different cultures. What's absolutely clear, though, from this body of anthropological and ethnographic research is that while the disease may be similar, the illness will be very different between different cultures. So if one takes a simple example, tuberculosis is a disease, but as far as how somebody with tuberculosis affecting the lungs might present in a sub-Saharan African country compared with in a respiratory medicine clinic in South London, there would obviously be hugely important differences. So the language describing the symptoms would be different, the attribution of the symptoms, the explanations for how this might have arisen might be very different, the nature of the help sought by those individuals would depend upon their interpretation of the symptoms that they were experiencing, all of which would be very, very much strongly culturally influenced. So in all of our work, we need to be clear at making this distinction between the disorder categories or the hypothesized underlying disease, which may indeed at a neuroscience level be very similar between different countries and cultures, and the understanding and the expression and the attribution of those illness experiences by individuals, which will be completely different. And obviously this will have an important implication for the nature of the assessments that one needs to carry out in order to identify people with those conditions, the way that one diagnoses different disorders, the way that one approaches the assessment and the treatment of these mental health conditions, again, will need to be culturally very, very different between different settings. At the same time, it's important to understand that there are commonalities, things that look pretty much the same between different countries and cultures when one studies using epidemiological research the nature of mental disorder and its associations. So the first thing is that the social determinants, which we'll discuss in a moment, of mental disorders tend to look very similar between different countries and cultures worldwide, and in pretty much every country studied, stigma and discrimination of people living with mental health conditions seems almost universal. Second, the burden of mental disorder, the types of condition that are particularly prevalent and also particularly burdensome in the nature of the social disability that's associated with them, that tends to be very, very similar. And unfortunately also the treatment gap is a problem in well-resourced high-income countries, but is in particular a problem in less well-resourced middle-income countries and low-income countries worldwide. So next, let's look at the burden of mental health conditions worldwide. And here I'd like to refer you to a review from the first Lancet series on global mental health conducted in 2007, which is still relevant, I think, to an understanding of the important nature of the burden of mental ill health and how this is distributed worldwide. So the first thing is, if we look at the burden from mental health conditions, or as it's termed in the Global Burden of Disease report, neuropsychiatric conditions, in terms of DALYs, or disability-adjusted life years. Now, the concept of a DALY is quite simple to grasp, really, because it incorporates both the disadvantages or years of life lost because of living long-term with a disabling chronic mental health condition, with the years of life lost because of premature mortality, into a single metric, the DALY, the disability-adjusted life year. And this looks at the proportion of the total disability-adjusted life years arising from ill health worldwide that are contributed by neuropsychiatric conditions as opposed to other types of disorders. And you can see that worldwide, nearly 15% of the global burden of disease is arising from neuropsychiatric mental health conditions. But this proportion is as high as 30% in high-income countries, falling down to 10% in low-income countries. Now, it's important to understand that this isn't because the prevalence of mental health conditions is less in low-income countries, nor that these conditions are less disabling. The reason for this can be properly appreciated if we look at the next slide, which looks at the DALYs per capita. In fact, the DALYs per 1,000 people attributable to different disorder groups according to country income levels. So we've got high-income countries here on the left, upper middle income, low middle income, and low income countries. And you can see here that there's just an awful lot more disease burden in low income countries, this is the total burden here, than there is in high income countries. So people are iller in general in low income countries. So the denominator for the proportion of the total burden attributable to mental disorders is higher in low-income countries than high-income countries. And we can see where this excess disease burden is coming from in low-income countries. It's here in light blue. This is the communicable, perinatal and maternal disorders. So this type of disease burden arising from maternal deaths, from infant deaths, from malaria and HIV and tuberculosis and diarrheal disorders, has been more or less completely eliminated, not completely, but more or less completely eliminated in high-income countries, but not sadly in low-income countries. But if one looks at the per capita burden arising from mental disorders, that is the dark blue part of the graphs here, one sees that it's a little bit less in low-income countries, but otherwise broadly similar across the world. And indeed, the evidence does suggest that there's not a great deal of difference in the prevalences of the major types of mental disorders across different countries and regions. Now, it's important to remember, because often people forget, that mental health conditions are non-communicable chronic diseases. If one looks at the current global health prioritization of non-communicable chronic diseases, then the conditions that are identified for action are cardiovascular diseases, cancer, and diabetes, but mental health conditions are in fact scarcely mentioned in the United Nations intergovernmental report that came out, for example, in 2012. However, if one looks at the total burden of non-communicable diseases, the burden of disease from non-communicable diseases, that's the circle, the pie chart here, one will see that actually the largest single contribution is made by neuropsychiatric mental disorders. That's 28% of the whole burden of chronic diseases worldwide comes from mental and neurological disorders. That's a bit bigger than the global burden of cardiovascular diseases, heart disease and stroke, which is 21%. It's much larger than the burden from cancer, which is 11%, and is also a lot larger than the burden from diabetes and other endocrine disorders, which is 4%. So it's clear that the relative prioritization of different chronic diseases doesn't actually represent their different contributions to global burden of disease worldwide. If it did, then a lot more attention would be given to neuropsychiatric and mental disorders in research and also in policy and in practice in health service funding than is currently the case in either high-income or low- and middle-income countries. If we look at how the burden of neuropsychiatric disorder breaks down, then one can see this here. So there's an important contribution, the largest of all, from unipolar affective disorder, which is essentially major depression. There's also an important contribution from the psychoses, that is schizophrenia here, and also bipolar affective disorder. Dementia makes an important contribution, particularly considering that this is a disorder mainly confined to older people. And then substance and alcohol use disorder also makes an important contribution, and epilepsy as well. Now, the Global Burden of Disease report suggests that while mental and neurological disorders contribute around 30% or more to the overall burden of disability, that years live with disability, the suggestion is that it makes a very minor contribution to years of life lost through premature mortality. But probably the Global Burden of Disease report underestimates the contribution of mental disorders to mortality because it doesn't include suicide deaths. These are listed under accidents and injuries rather than under the major mental health category. Back in 2007, there were estimated to be 800,000 suicide deaths annually. That figure has certainly increased to over 1 million now. And as regards these suicide deaths, it's thought that around 80% of those occur in the context of a serious mental illness, and around 50% of the mortality arising from suicide can actually be attributable to an underlying mental disorder. That is, the presumption is that if that mental health condition could be treated successfully or prevented, then those suicide deaths, half of them, would not have occurred. But it isn't only suicide-related mortality that is an issue as far as major mental health conditions are concerned. So there's an increased risk, twofold up to 2.5-fold, of non-suicide mortality that's been noted for all of the major mental health conditions. And what's clear is that when one controls for the fact that individuals with some of these mental health conditions may have adverse lifestyle factors, they may be more likely to smoke, to be obese, less likely to take exercise, the increased mortality is not explained simply by that. There may be underlying biological mechanisms in some cases, drug side effects, for example, antipsychotic drugs used to treat conditions like schizophrenia may increase mortality somewhat. But it seems that the likeliest explanation for most of this increased mortality is because of limited access to general health care for physical health conditions, and then the poor quality care that people with serious mental health conditions receive for other physical health conditions that they may be experiencing. To look in a little bit more detail at the suicide issue, this was an interesting nationally representative study of 1 million deaths conducted in India with verbal autopsies to try and estimate what the cause of death was in each of those cases. And here one can see the age-standardized incidence of suicide mortality for men and for women in India, which is the red line here, and then for high-income countries, which is the blue line here. And one can see that there's a bit of an excess suicide-related mortality amongst young men in India compared with in high-income countries. But look at this enormous excess of suicide mortality amongst young women in India. And this is women essentially aged between 15 and 35, so women of childbearing age. And interestingly, actually, suicide is the number one cause of death amongst young women in India. This was a new fact established by this very large study conducted in India. It has a similar or slightly higher mortality than maternal deaths. But maternal deaths are obviously, quite rightly, hugely prioritised within the Indian public health system, and a lot of activities are introduced in order to make childbirth and the perinatal period safer for women. But it turns out that actually suicide is an equally or perhaps even more important cause of death amongst women of that age in that country. So another reason why there could be no health without mental health is that it's pretty much impossible to actually separate out mental and physical health conditions given their very high comorbidity. That is, the two very often occur together. And in the Lancet review, we looked at this from three different perspectives. We looked at whether or not mental health conditions increased the risk of developing a physical health condition. Then we looked in turn at whether the physical health condition increased the risk for developing a mental health condition. And given that there might be a lot of comorbidity then between mental and physical health conditions, we looked at the effect of the mental health comorbidity on the treatment and care for the physical health condition, whether it reduced help seeking, whether it was associated with under-detection and under-treatment, whether the adherence to the treatment plans for the physical health condition was adversely affected, and whether the prognosis of the physical health condition was adversely affected by the comorbidity with the mental health condition. Now, the scope of this review was very wide, but if one considers for a moment HIV infection, then it's clear that there is evidence that people living with alcohol and substance use disorders, people particularly who inject substances and share needles, also people living with psychoses and possibly depression as well, are at increased risk of seroconversion, that is, being infected with HIV. Then in turn, for those who are infected with HIV, because the virus infiltrates the central nervous system, there is a risk of cognitive impairment and of dementia. There's a very high prevalence of depression associated with HIV seropositivity, as high as 30% for major depression, for example, and this is probably associated both with infiltration of the central nervous system, but also obviously with the adverse impact that the diagnosis and the stigma of the diagnosis might have on an individual's life. Now, unfortunately, there's also evidence that people living with HIV who have depression, who have cognitive impairment or dementia, who have a comorbid psychosis, experience a worse outcome as far as the treatment of their HIV condition is concerned. So they are slower to get a diagnosis, they're more likely to drop out of care at the early stages before they start antiretroviral treatment. In particular, their adherence to antiretroviral treatment is suboptimal, and this is a crucial issue for HIV treatment because adherence needs to be as high as 90% of all of the tablets at the right time with a complex treatment protocol. Otherwise, the HIV virus can reappear in the bloodstream, the CD counts go down, and as a result of this, one can become unwell again, and the mortality rate is higher for people with those comorbid mental health conditions than for others on antiretroviral treatment programs. So currently, this issue of poor adherence and mental health comorbidity is rightly becoming prioritized within HIV programs as a new focus for treatment and care. For all of these reasons, compartmentalising, separating out mental from physical health, does nobody any favours at all. As we've seen, it probably underestimates the overall burden of mental disorders. In particular, it misses the important links that exist between mental health and mainstream health and human development, and we'll consider ways in which that might be in a moment. In particular, I think, it tends to entrench the isolation and neglect of services and the stigma of those affected, because the separation of mental health treatment services with underfunded asylum hospitals, which are difficult to access, leads to the stigmatization of people that actually deliver those services and treatment, as well as the people that receive them as well. Whereas if this were integrated in a normal fashion with treatment and care for other disorders at the level of primary and secondary care, then arguably a lot of these problems of stigma and discrimination could be reduced. And we've talked about how mental health may be relevant to the combating of HIV/AIDS. There is also evidence that is considered in the review that mental health conditions, in particular antenatal and postnatal depression in the mother, may be important for the reduction of child mortality and also, of course, for the improvement of maternal health. So, if one were approaching a minister in a low-income country, for example in sub-Saharan Africa, then this would probably be what would be on that minister's priority in tray. These are the Millennium Development Goals for achievement by 2015, the improvement of child health, the improvement of reproductive health, and the control and eradication of communicable diseases. And if mental health was anywhere on that policymaker's list, it would be right down at the very bottom, and it would probably be in very low and small print. So we could say to that minister, Minister, have you not read the Global Burden of Disease report and the No Health Without Mental Health Lancet Review? Don't you realise that actually mental health should be front and centre of everything that you're doing and prioritise much more than it currently is? But probably that would attract very little attention from the policymaker or the minister, who would show you the door. And a much more nuanced and sophisticated approach would be to actually demonstrate the many links that exist between mental health and the programmes that are currently being delivered in these areas. And the policy and the plan that should be promoted is one of integrating attention to treatment and care for mental health conditions in the context of the platforms of care that are already prioritised and funded within these settings. So next, the problem of inequity and human rights experienced by people living with mental health conditions. So the first thing to note, and we'll present some evidence on this in a moment, is that living with a mental disorder is associated with a cycle of disadvantage. So particularly for depression, living under conditions of socioeconomic adversity and poverty increases the risk of developing depression. Then on the other hand, developing depression often leads to loss of employment, loss of livelihood, and a drift downwards in the socioeconomic scale within the setting in which you live. So this is a cycle of disadvantage. And this cycle of disadvantage, particularly coupled with the stigma and discrimination that's associated with the major mental disorders, in particular the psychoses such as schizophrenia, means that the voices of people living with mental health conditions are rarely heard and rarely heeded. And so it's very easy for their human rights to be disregarded. And the particular concern regarding the inequity experienced by people with mental health conditions is the way that their human rights are not respected and traduced, often by the very services and systems that are designed to be there to provide them with supportive treatment and care. So there are many issues and difficulties here which are listed on this slide. In many countries, resource-poor countries, there is no legislation that provides protection for people who, for example, are detained against their will in mental health treatment facilities. There's no right of appeal. The legislation, if it exists, is often very outdated and is not implemented properly within the legal systems. People with mental health conditions often are not treated in mental hospitals, but are actually imprisoned, not for having committed a crime, but simply for exhibiting signs of a mental health condition in a public place. The conditions of care and treatment are often completely inhumane in their quality and in the nature of the interactions with the treatment staff. Restraints and seclusion are far too often used and again are not monitored. There are problems with both physical and sexual abuse in the community and also in these treatment facilities. And above all, there is a lack of effective advocacy. There's no strong constituency that exists within many of these countries bringing together users of mental health services and their families in order to demand a change and to hold governments and systems to account for the level of care that they provide. The newspaper cutting provides one stark and shocking example of the type of problem that is experienced in some of these settings. This was the asylum fire in Irrawaddy in Tamil Nadu in India, which occurred in 2001. It says here that 25 people died, in fact 38 people in total died, and the story here was that this was not actually a mental hospital. This was an informal traditional healer centre that was set up for people living with psychosis in Irrawaddy, which was a community with holy waters and where tradition held that propitious conditions existed for the treatment and improvement of mental health conditions. But the inmates of this particular asylum were all shackled. They were chained. And at night time there was no one there to provide supervision for them. It's not known whether this was a case of arson, a deliberate fire setting, or whether it was an accidental fire, but no one was there to assist the individuals, and everyone within that asylum died. Now one could say that's a traditional healer facility, but the traditional healer facility only existed because of the lack of publicly available, accessible biomedical treatment and care for these major mental disorders, and it should have been properly supervised by government. The Indian government then got involved and they ordered that shackling was to be made illegal, and they introduced a series of 5-year plans in order to improve accessible treatment to mental health care. But unfortunately, if one visits India today, one still finds people who have a lot of difficulty in accessing care, and one still finds institutions such as the Irrawaddy institution, and one will still find individuals who are shackled. So the link between poverty and mental disorders, there's a very helpful couple of reviews that were conducted by Crick Lund and colleagues, looking at the evidence base, first of all from cross-sectional studies and then from longitudinal studies. This is the review of the pattern of association that's found in low and middle income countries from the cross-sectional studies. And from this review, it was apparent that the very large majority of studies did show a positive association between living in poverty and having an increased prevalence or increased incidence of common mental disorders such as depression and anxiety disorder. This association was very well known and understood in high-income countries, but the evidence hadn't been previously brought together for low and middle-income countries. But the interesting thing is if one looks at the pattern of associations and the mediators for this, so if we start over at the left, we see a range of different possible indicators of poverty and consequences of poverty. So people live in a situation of economic deprivation with low incomes. They get into problems with debt. Many of them have structural problems such as not having been educated or having very low levels of education. Unemployment is common. Access to basic amenities is an issue. Housing is often grossly inadequate with a lot of overcrowding. So these structural factors lead to social exclusion of people living in poverty, a lot of stress, problems with malnutrition, difficult pregnancies and childbirth, and there's also a very strong association with violence and trauma, particularly interpersonal violence or intimate partner violence, which women generally experience. So all of this increases the risk of such individuals for having an episode of mental ill health, which is often a common mental disorder such as depression or anxiety disorder. So one sees a higher prevalence of these problems. One also sees poor access to mental health care because of the structural difficulties that they experience. And one also then sees generally a more severe course, so a longer episode of living with depression than would have otherwise been the case for people not living in poverty. So being depressed and anxious, staying that way for a longer period of time, not getting access to treatment, leads to an increased health expenditure, often a loss of employment, then reduced productivity, and so a social drift in the social position, the socioeconomic position of that individual, and often their family and their household if the person who is affected is the main breadwinner. So this again exacerbates the poverty that the individual and the household experience, and one goes round this cycle. So an important question is where and how interventions might actually break this cycle of poverty and mental ill health. And that's where the second review conducted by Kricklund and his colleagues is a very useful source of evidence. And in this review, Crick and his colleagues looked at two issues. Whether efforts to alleviate poverty improved mental health outcomes, and whether mental health interventions designed to improve mental health status actually improved livelihoods and economic outcomes. And what turned out was that the evidence was much stronger that mental health interventions improved economic outcomes than that poverty alleviation improved mental health outcomes. Although few studies had been carried out on that issue, the research was considered to be inconclusive. So definitely there is very strong evidence for pervasive links between poverty as a social determinant of risks for common mental disorders, and there seems to be evidence that intervening against mental disorders may actually improve people's economic situation and outlook. But it probably is the case as well that poverty alleviation at the macroeconomic level can improve the mental health of a society, although this needs to be looked at in more detail. Conversely, it could be that societies in which income inequalities are growing, and also societies which experience catastrophic economic failure, for example, the Eurozone crisis affecting Greece, crop failures in India and some parts of sub-Saharan Africa, there are probably major impacts on mental health generally. Increases in suicide rates have been suggested in many of these settings, but the evidence base for this is one that needs further attention. The focus for this thought then is looking at how treatment and care can be made more available to people living with mental health conditions, how we can mind the gap, that is, how we can reduce the treatment gap that currently exists. So to introduce you to the treatment gap and its extent in different countries and cultures worldwide, these are data from the World Mental Health Survey conducted in many different countries worldwide. And this is looking at people with severe common mental disorders, that is, severe depression, severe anxiety disorder, or other common mental disorders, and the proportion among them that have received any evidence-based treatment at all for that mental health condition over the last 1 year. And you can see that even in high-income countries, at best, slightly less than 2/3 of people with severe forms of common mental disorder have actually received any evidence-based treatment or care whatsoever in the last year. But then when one looks at low-income and middle-income countries, one sees that actually only 10 to 20% of such individuals have actually received access to that treatment and care. Put the other way, that means that the treatment gap is in the order of 80 to 90% of individuals who should have benefited but are not actually receiving this treatment or care. If one looks at rural communities in sub-Saharan African settings, for example, so amongst the lowest income countries in the world, in these settings, the only treatment and care for a condition like schizophrenia that has been made available is usually in the capital city, and there's usually one large asylum hospital, so an individual with schizophrenia might need to travel a long distance with their family at considerable cost if they know about the service in order to access treatment and care. Not surprisingly, that doesn't often happen. In a large community survey conducted in Butajira in rural Ethiopia around 8 years ago, 90% of all of the individuals with severe mental illness, that is psychosis like schizophrenia or bipolar affective disorder, had never received any treatment or care for their condition whatsoever. The treatment gap was 90% for the most severe mental illnesses. And one could see the consequences of living with an untreated serious mental disorder with this gentleman here on the left, who is kept shackled in his hut. His family probably had no choice in this because of the behaviour disturbance, the agitation, the aggression that he may sometimes have shown because of the symptoms of psychosis, the voices that he's hearing telling him to do things, the delusions, the false beliefs that he has about what's going on in the world around him. Now, this particular person was the beneficiary of a community treatment program that was introduced by the principal investigator, Professor Atwell. Having identified 700 people like this in the community with serious mental illness, Professor Atwell realised that it would be completely unethical simply to observe and not actually provide a service. So he initiated a program run by 2 community psychiatric nurses who were working from the base hospital in Buttigieg. And gentlemen like this one on the left had their lives and their outlooks transformed by receiving simple community treatment with antipsychotic medication and some community-based rehabilitation in order to restore and encourage the restoration of their work patterns and their livelihoods. And so you can see that after the treatment, this gentleman and his brother, who also were suffering from schizophrenia, actually returned to work on their family farms and actually transformed the fortunes of those farms as well, converting them again into economically successful businesses. This was a meeting that I went to, was privileged to go to on the very first day that I visited Ethiopia back in 2002. And this was a community meeting organised by Professor Atwell to look at the future of the community-based programme that he'd set up in Buttigieg. This was a very moving occasion in which, one after another, people who were the beneficiaries of the treatment programme, both people living with psychosis, their family members, community leaders, stood up to attest to the importance of the programme and the changes that it had made to their lives, and asking that this programme be strengthened and continued within the community. So our challenges are finding ways to actually generalise programmes like the one provided in Ethiopia more broadly across resource-poor settings, and the obstacles to do this are considerable, as indicated in the 2nd and 4th reviews for the Lancet series on global mental health. So these looked at the resources available for mental health in different countries and cultures worldwide. And the resources considered included policy and legislation, mental health services, including hospital services, number of mental health professionals available, community resources, and funding. And the simple conclusion was that the resources were scarce. They were distributed in a very unequal way, in particular between countries and between urban and rural settings within countries, and that the patterns of use of these resources was characterised by gross inefficiency. So if we have a look at this for a moment, this slide looks at the human resources per 100,000 of population for low-income countries, for lower middle-income countries, for higher middle-income countries and high-income countries, for psychiatrists, psychologists, psychiatric nurses and social workers. Now clearly the resources available are much higher in high-income countries than they are in lower-income countries, but I think the remarkable thing here is that the resources in low-income countries are so limited that you actually can't even see the bar on the graph. So across pretty much the whole of sub-Saharan Africa, South and Southeast Asia, there is fewer than one psychiatrist per 10 million population. It's a negligible resource, and most people with mental health conditions in those settings cannot hope to be treated realistically by a specialist, by a psychiatrist, a psychologist, even a psychiatric nurse. Our only hope in these settings for scaling up mental health care is task shifting and task sharing, that is using non-specialist health workers suitably trained and supervised by the few psychiatrists, psychologists and psychiatric nurses that there are. Then inefficiency. The specialist resources that are currently available are used in a grossly inefficient way. Firstly, they tend to be completely centralised in mental hospitals rather than in the community, and in cities rather than in rural areas. So usually more than half of the mental health budget, 2/3 for the inpatient beds, and more than half of all of the nurses are centralised in one asylum, not providing treatment and care for the rest of the country. Next, there's an inefficient reliance often on out-of-pocket payment for receipt of services. So even if you get to the centralised hospital, you need to pay to see the doctor, you need to pay for the admission, and you need to pay for the treatment. And the problem with this is that it often leads to catastrophic expenditure because you get admitted, you have a lot of payments to make, you then leave hospital with a supply of medication, but when that medication runs out, your money has run out as well. And so you don't go again to the hospital in the main city to get your medication resupplied. After a period of time off medication, you're likely to relapse and become unwell again, and this whole cycle of catastrophic expenditure recurs. Much better to have accessible treatment close to where the person lives with continuous treatment and care, and avoiding these unnecessary cycles of catastrophic expenditure. So Ban Ki-moon, the director of the United Nations, said back in 2009 on World Mental Health Day, providing effective mental health services in primary care settings would help to reduce the stigma associated with mental disorders, but prevent unnecessary hospitalisation and human rights violations of people with mental health problems. Such a strategy makes good economic sense. It is also pro-poor. Let us this year resolve to reduce the public health burden and the individual suffering of people with mental health problems worldwide. So Ban Ki-moon was absolutely correct, and having this sort of high-profile statement made by somebody of his stature at that time was obviously extremely helpful to the movement for global mental health generally.